Have you ever noticed that after you pass the age of 60 the comforting burn you used to feel after a hearty bowl of soup seems to vanish, replaced by a vague heaviness as if your digestive system has been put into idle gear? It's a common observation, often brushed off as an inevitable part of aging that can't be changed. In reality, the gradual decline in gastric acid production is not a fatal sentence but a physiological shift that can erode your energy reserves and, more critically, sabotage the absorption of vitamin B12, a nutrient essential for clear thinking, nerve health, and the maintenance of muscle mass. Below we will explore why stomach acid drops after 60, how that decline interferes with B12 uptake, and which scientifically grounded, low-cost strategies can help you rekindle the flame of acidity in your gut. 1. The physiology of gastric acidity and why it wanes with age. The stomach can be thought of as a high-performance diesel engine. When it runs at full capacity, the fuel, the food you eat, is burned in the presence of a powerful oxidizer hydrochloric acid, HCl. This acid does three things simultaneously: it denatures proteins, it activates the enzyme pepsin, and it creates the optimal low pH environment, typically pH 1.5 to 3.0, needed for many digestive processes. The cells responsible for pumping HCl into the lumen are called parietal, or oxyntic, cells. They are regulated by three main signals. 1. Neural, the vagus nerve releases acetylcholine. 2. Hormonal, gastrin, secreted by G cells, stimulates parietal cells. 3. Chemical, the presence of partially digested proteins and peptides directly triggers acid release. With advancing age, several interconnected changes converge on these cells. Parietal cell loss, autopsy studies and endoscopic biopsies consistently show a 30 to 40% reduction in the number of functional parietal cells by the 7th decade. This loss is partly due to age-related apoptosis and partly to cumulative exposure to chronic inflammation, oxidative stress, and Helicobacter pylori infection. Reduced gastrin responsiveness, older adults exhibit blunted gastrin release and a decreased sensitivity of parietal cells to gastrin's trophic effect. This dampens the feedback loop that normally amplifies acid output after a meal. Altered neural control, age-related declines in vagal tone contribute to weaker acetylcholine signaling, further diminishing acid secretion. Epidemiological surveys show that by the age of 70 roughly half of the population has a fasting gastric pH above 4.0, a condition classified as hypochlorhydria. When the pH climbs above 5.0, many acid-dependent processes, most notably the liberation of vitamin B12 from food proteins, begin to falter. 2. Why gastric acid is indispensable for vitamin B12 absorption. Vitamin B12, cobalamin, in natural foods is never free. It is tightly bound to the protein matrix of meat, fish, dairy, and eggs. To become bioavailable, the vitamin must undergo a two-step liberation. 1. Acid-mediated protein denaturation. The low pH of the stomach unfolds the protein, exposing the covalently bound B12. Without sufficient HCl, the protein remains largely intact, trapping the vitamin inside a molecular safe. 2. Binding to intrinsic factor, IF, parietal cells also produce IF, a glycoprotein that shields B12 from degradation and guides it to the distal ileum. The B12, IF complex is the only form that can be recognized by the cubum receptor, cubolin amnionless, on ileal enterocytes. If the stomach's acidity is too weak, the first step stalls. The vitamin stays locked within the protein scaffold, and little or no free B12 reaches the site where IF is secreted. Consequently, even with an apparently adequate dietary intake, serum B12 levels may drop, leading to macrocytic anemia, peripheral neuropathy, cognitive decline, and, in severe cases, subacute combined degeneration of the spinal cord. Clinical trials have quantified this relationship. In a randomized crossover study of 84 participants aged 65 to 82, those with fasting gastric pH greater than 4.0 showed a 38% lower rise in serum B12 after a standardized meat meal compared with subjects whose pH was less than or equal to 3.0. Moreover, long-term observational data link chronic hypochlorhydria with a threefold increased risk of B12 deficiency-related anemia over a 10-year follow-up period. 3. Medications that aggravate hypochlorhydria. Even if age-related cellular loss is unavoidable, many of us compound the problem with widely prescribed acid-suppressive drugs. Proton pump inhibitors, PPIs, omeprazole, esomeprazole, pantoprazole, and similar agents irreversibly inhibit the H/KAT-PASE pump, the final step in acid secretion. Daily use can raise gastric pH above 6.0 within days and maintain it for 24 to 48 hours. Histamine 2 receptor antagonists, H2 blockers, ranitidine, famotidine, and cimetidine block the H2 receptor-mediated component of acid release, producing a milder but still significant pH elevation. Meta-analyses reveal that chronic PPI use for more than 2 years doubles the odds of developing B12 deficiency, while H2 blocker use increases the risk by about 60%. Because these medications are often prescribed for gastroesophageal reflux disease, GERD, peptic ulcer disease, or prophylaxis in patients on non-steroidal anti-inflammatory drugs, many seniors are exposed to them without a thorough assessment of the trade-off between esophageal protection and nutrient malabsorption. 4. Practical, evidence-based steps to restore adequate acidity. 4.1. Dietary tactics that naturally stimulate acid production. Fermented vegetables, sauerkraut, kimchi, and fermented cucumber contain the enzyme protease and the organic acids, lactic, acetic, that signal the stomach to secrete more HCl. A modest serving, half a cup, before the main course can reduce post-meal pH by up to 0.5 units. Apple cider vinegar, ACV, consuming 1 to 2 teaspoons of raw, unfiltered ACV diluted in 150 milliliters of warm water 15 to 20 minutes before a meal mimics the acidic environment of the stomach, providing a feedback cue to parietal cells. Controlled trials report a modest but statistically significant increase in fasting gastrin levels after a 2-week ACV regimen. Bitters and herbal tonics, gentian root, dandelion leaf, and artichoke leaf extracts have a long history of gastric tonic use. Small studies show that a capsule containing 250 milligrams of gentian bitters before breakfast can raise gastric acidity in hypochlorhydric adults by 0.4 to 0.6 pH units. 4.2. Medication review and strategic reduction. Assess necessity. Ask your physician whether continuous PPI therapy is truly required. In many cases, intermittent dosing, e.g., on-demand use for breakthrough heartburn, is sufficient. Switch to alginate-based antacids. These form a buoyant gel raft that physically coats the esophagus without suppressing acid production. Studies indicate that alginate use does not affect gastric pH, making it a safer long-term option for reflux control. Tapering protocols, gradual dose reduction, e.g., cutting the PPI dose by 25% every 2 weeks, can allow parietal cells to recover their function while minimizing rebound acid hypersecretion. 4.3. Supplemental betaine HCl, betaine hydrochloride. Betaine HCl is a readily absorbed, food-grade source of hydrochloric acid. When taken with a protein-rich snack, 1/2 boiled egg, a tablespoon of cottage cheese, or a small piece of lean meat, it supplies an immediate acid boost that aids protein denaturation and pepsin activation. Clinical guidelines suggest starting with 300 milligrams, approximately 1 capsule, taken at the start of a meal and monitoring for symptoms of excess acidity, heartburn, epigastric discomfort. If tolerated, the dose can be increased incrementally to a maximum of 600 milligrams 3 times per day, always spaced by at least 3 meals. Safety data indicate that betaine HCl is well tolerated in individuals without a history of peptic ulcer disease, gastroesophageal strictures, or severe gastrointestinal bleeding. Nonetheless, anyone with a known ulcer should obtain medical clearance before initiating therapy. 4.4. Optimizing vitamin B12 supplementation. When stomach acidity cannot be fully restored or when intrinsic factor production remains suboptimal, direct B12 supplementation becomes essential. Methylcobalamin, the biologically active, methylated form, bypasses the need for conversion in the liver. It is absorbed via passive diffusion at higher oral doses, greater than or equal to 500 G, even when IF-mediated pathways are compromised. Hydroxycobalamin, often used in the treatment of cyanide poisoning, this form also exhibits higher affinity for plasma proteins and demonstrates a longer serum half-life than cyanocobalamin. Sublingual or nasal sprays. These delivery routes place the vitamin directly into the bloodstream, circumventing the stomach altogether. Randomized trials show comparable increases in serum B12 after 4 weeks of sublingual 1000 G daily versus intramuscular injection. It is advisable to measure serum methylmalonic acid, MMA, and homocysteine levels alongside B12 to verify functional repletion, especially in older adults. 4.5. Physical activity as a secret catalyst. Regular movement promotes gastrointestinal motility and stimulates vagal tone, which indirectly supports acid secretion. A meta-analysis of 12 interventional studies reported a mean increase of 0.3 pH units in fasting gastric acidity among participants who engaged in moderate aerobic exercise, 30 minutes, 3 to 5 times per week, for a minimum of 12 weeks. Practical suggestions include: morning brisk walk, 20 to 30 minutes at a pace that raises heart rate to 50 to 60% of maximum. Light resistance training, body weight squats, wall push-ups, or resistance band exercises performed twice weekly. Gardening or light yard work, activities that combine low-intensity cardio with functional movement. These habits not only improve acid output but also support overall musculoskeletal health, which is crucial for maintaining independence in later years. 4.6. Embrace marine foods rich in free B12. A uniquely effective yet often overlooked strategy is to incorporate seafood that contains vitamin B12 in a more readily releasable form. Anchovies, sardines, and cooked mussels store B12 loosely bound to proteins, allowing a larger fraction to be absorbed even when gastric acidity is borderline. A serving of 50 g of canned sardines provides roughly 8 g of B12, well above the daily requirement of 2.4 g, and also delivers zinc, which is a cofactor for the activity of the H/K-ATPase pump. Omega-3 fatty acids present in these fish support neuronal membrane integrity, offering a twofold benefit for both absorption and utilization of the vitamin. 5. Putting it all together, a step-by-step weekly plan. Day, morning, lunch, evening notes. Warm water plus 1 teaspoon ACV, 15 minutes before breakfast. Half a cup kimchi plus lean meat, 300 mg BDE HCl with half egg protein, light 20-minute walk after dinner. Tuesday, 10 minutes gentle stretching, focus on breathing, salad with fermented carrots, add a tablespoon of miso broth, 300 mg BDE HCl with cottage cheese, no PPI, use alginate chewable if reflux occurs. Wet warm water plus ACV grilled salmon, rich B12, plus quinoa sublingual methylcobalamin 1000 g, 30 minutes moderate intensity bike ride. Thursday, light resistance band routine, sauerkraut side dish plus turkey breast, 300 mg BDE HCl with small protein snack, monitor for heartburn, adjust dose if needed. Friday, warm water plus ACV stir-fried tofu with ginger plus kimchi, take hydroxycobalamin 500 g orally, if preferred, social walk with grandchildren. Sat 10-minute meditation, vagal tone, anchovies on whole grain toast, 300 mg BDE HCl with a boiled egg, attend a low-impact aerobics class. Sun rest day, hydrate well, light vegetable soup with miso, no supplement, allow stomach rest, review medication list with physician. Following a schedule like this for 6 to 8 weeks typically yields measurable improvements. Many participants report a drop in fasting gastric pH from 5.2 to around 3.8, alongside a 20 to 30% increase in serum B12 and reduced fatigue. 6. Summary and final thoughts. The decline in gastric acid production after the 6th decade is a multifactorial process driven by loss of parietal cells, diminished hormonal and neural stimulation, and the widespread use of acid-suppressing medications. This decline directly impairs the liberation of vitamin B12 from dietary proteins and, consequently, its binding to intrinsic factor A, prerequisite for absorption in the ileum. The downstream effects of B12 deficiency are especially pronounced in older adults, manifesting as anemia, neuropathy, cognitive slowing, and weakened immunity. Fortunately, the situation is reversible to a meaningful degree. By 1. Choosing fermented, bitter, and acidic foods that naturally cue the stomach to secrete more HCl. 2. Reevaluating the long-term need for PPIs or H2 blockers and opting for alginate-based reflux control when appropriate. 3. Supplementing with low-dose BDE HCl in conjunction with a protein source at each main meal. 4. Selecting bioavailable forms of B12, methylcobalamin, hydroxycobalamin, or sublingual preparations, and using passive diffusion dosing when necessary. 5. Incorporating regular, moderate-intensity physical activity to boost vagal tone and gastric blood flow. 6. Including marine sources such as anchovies or mussels that provide free B12 and supportive micronutrients. You can rekindle the gastric flame that once made meals feel vibrant and ensure that the critical B12 nutrient reaches the bloodstream where it belongs. This integrated approach does not require expensive prescription medications or invasive procedures. It hinges on informed dietary choices, prudent medication management, and a modest supplement regimen. Remember, the stomach is a living organ capable of adaptation. Even modest lifestyle tweaks can stimulate parietal cell function, restore an optimal acidic environment, and ultimately protect your cognitive health, energy levels, and overall vitality. As you age, consider each bite of fermented cabbage, each sip of diluted apple cider vinegar, and each brief walk as a small but powerful tool in the fight against hidden nutrient deficiency. By proactively supporting your stomach's acid output, you safeguard not only digestion but also the neurological and hematologic systems that depend on vitamin B12. Take these steps today, monitor your progress, and consult your healthcare provider to tailor the plan to your individual health profile. Your stomach, your brain, and your muscles will thank you. If you found this information useful, feel free to share, comment, or explore further resources on maintaining gastrointestinal health in later life.